mən indi konferansımızın ilk keynote speakerini dəvət edirəm. Burada çox qısa bir balaca bir hekayə demək istəyirəm. Biz konferans üçün speakerləri araşdıranda mən sözün düzü daha öncəsində Kamran doktoru tanımırdım. Mənim cahilliyimə tamamilə bağlayıram. Və mən Kamran doktorun profilini görəndə inanılmaz dərəcədə çox sevindim və çox həyəcanlandım və həmin gün hələ də xatırladım, bir neçə saat onun profilində, web saytında xərclədim. Sonrasında elmi tədqiqatlarını araşdırdım və əmin idim ki, biz Kamran doktoru konferansda mütləq şəkildə görmək istəyirik. Kamran doktor yəni çox möhtəşəm bir CV-si var və buradakı hamının da tanıdığı kimi çox dəyərli bir elm adamımızdır. Mən qısa bir introduction eləmək istəyirəm haqqında. Deməli, Kamran doktor 2001-ci ildə ATU-da tibb təhsilini bitirdikdən sonra Türkiyənin Hacettepe Universitetində neyrocərrahiyyə istiqamətində rezidenturaya başlayıbdı. Daha sonra o, Floridada Moffitt Xərçəng Mərkəzində spinal onkologiya əsasında kliniki fellowship edib. Kamran doktor tibbdə 5500-dən artıq əməliyyatla yanaşı, əminəm ki, bu sayı indi daha da çoxdur, bir sıra böyük ixtiralar və töhfələr veribdi sahəyə. Xüsusilə Thoracic Outlet Syndromunda PURE adlanan Posterior Upper Rope Excision və Decompression texnikasını inkişaf etdiribdi, kəşf edibdi. Hal-hazırda Kamran doktor Türkiyədə özəl xəstəxanada fəaliyyət göstərir. Və Kamran doktorun çıxışını böyük bir maraq və səbirsizliklə gözləyirik. Buyurun Kamran doktor.
Çox sağ olun, çox sağ olun. Təqdimatdan sonra biraz çıxış eləmək biraz çətindir. Mən çox üzr istəyirəm. Çünki mən prezentasiyamı hazırlayanda İngiliscə hazırladım. Daha doğrusu bundan öncə verdiyim bir neçə dənə prezentasiyamı hazırladığım prezentasiyaları birləşdirib bir prezentasiya haline getirdim. Ona görə əgər etiraz yoxdursa, mən Azərbaycanca danışmaqda biraz çətinlik çəkirəm müəyyən dərəcədə. Türkçəm biraz daha axıcıdır. Ona görə əgər icazə varsa mən İngiliscə davam etmək istəyirəm. Çox sağ olun. Basically I'm going to talk about the innovations that I've made so far. And I believe that I've made some innovations, some contributions to the field of neurosurgery. I tend to believe that any scientist, it doesn't matter if it's a clinical scientist or a basic scientist, passes through several stages in his career. So, first of all, initially you think or you assume that science is all about publishing papers, okay? And that's what then everybody else is expecting. So you're publishing, and the more you're publishing, the higher impact journal you're publishing. It's kind of great, and that's basically driven the industry. But at some point, you figure out that you sit down, and if you have time, and you think about, what did I do? Did I make any difference? And then you figure out that most of your contributions are basically just an updated version of what was existing before. So I hit the point in my career approximately 10 years ago, 9-10 years ago, when I figured out that I don't want to do publications anymore. I just want to do innovations, things that matter. Okay? And so the first question was, what is innovation? What matters? So Dr. Rahimli gave an excellent speech about the endoscopic-assisted skull-based surgery. Okay? He's an expert in the field. And in the beginning of his speech, he basically talked about this debate between the microscopy versus endoscopy. And I remember in my early resident years, we were talking about it, okay? And we are residents, we were driven by innovation. We knew exactly that endoscopy is going to win. Now the debate is settled. Now everybody knows that the future is endoscopy. So microscopy has no future, at least in the classical form. So I defined for myself innovation as a contribution that changed the field in an irreversible way. So there's no way back. So once you do it, the field is changed in a way, so there is no way back. And that's kind of a fundamental changes. So with this in mind, so I would like to share with you today things that I think I've contributed so far, right? So today we're going to focus on three main things. The first thing is a pure approach, the posterior approach that I've developed over the last 10 years for a thoracic outlet syndrome. Second, resection of osteophytes for a diffuse idiopathic skeletal hyperostosis. And the third thing is a fusion, sacro-lumbar interbody fusion using transdiscal route. So the three things that I think that kind of define me at this point of my career. So the first thing is thoracic outlet syndrome, and the motto for this part of presentation is show no mercy. And you'll understand what I mean by saying show no mercy. Because I believe that surgery has some similarities with the military, at least on strategic level. So, how many people here familiar with the thoracic outlet syndrome? Good. We have 4 people. Well, very good start. So, thoracic outlet syndrome is a medical term basically describing number of conditions associated with the compression of nerves and or vessels in the upper thoracic area. It's kind of happening in between the clavicle and the first rib. And it divided into 3 variants, neurogenic, which is the most common, which is 90% of cases. And I think we're going to have a talk about the migraine later on. Okay, so significant portion of migraine patients have a thoracic outlet syndrome. In fact, the migraines, the headaches, are caused by the thoracic outlet syndrome. And venous, if it's a compression of the subclavian vein, and the arterial one, which is the least common. So everything is happening in this area. So this is the interscalene triangle, where the scalene muscles are making a triangle over the first rib, and the neurovascular bundle passes through, and everything passes underneath the clavicle bone here and over the first rib. So that's the area. And there are several factors. I don't want to dive deep into these factors. I mean, there are cervical accessory ribs, and I think that has to do with previous talk about the cilia. Because as Dr. Elkan told us, that the problem with development lead to maldevelopment of the spine, and especially with a segmentation problem. And if you have a segmentation problem, then the patient tends to develop the extra ribs. So, and these extra ribs can cause the thoracic outlet syndrome. In addition to that, there might be costoclavicular impingement and the fibromuscular bands and a bunch of other things. I don't want to go into details. There are 19 different types of bands that can cause TOS. I don't want to dive deep into that. But I just want to jump into the treatment. So basically, classically, we say that there are, first, the patient should go through a conservative treatment and then through the surgery. And in surgery, we basically have 2 types of surgery: the rib sparing techniques, when we don't remove the first rib, and then we remove the first rib. And when we remove the first rib, we have a bunch of techniques like coming from the front and coming from the armpit, and then a bunch of other things. So let's dive deeper. So this paper was published quite recently. It comes from Netherlands. Basically, they came to the conclusion that surgery has clear advantage over continuous conservative therapy with a thoracic outlet syndrome. And this is understandable, because in most cases, the disease is caused by the mechanical compression. So unless you remove that mechanical compression, the patient is not going to improve. Then when we go to the surgical area, then we have 2 options. I mean, removing the rib or not removing the rib. And the point is that the more you remove the first rib, the higher the likelihood of good outcome. And this has been published, and this has been confirmed and reconfirmed many, many times by multiple independent study groups. But unfortunately, from a technical standpoint, these are the papers. These are papers coming from different groups, from Italy, from United States, and from other places in Europe, and even from Japan, basically stating that the more you remove the first rib, the better the outcomes. So this is a typical case of a surgically treated thoracic outlet syndrome. So you see, this is the intact first rib on the right-hand side, and you can see the part of the rib has been removed on the left side. But you can see that the front part of the rib and the back part of the rib remain in place. And unfortunately, most of these patients suffer from recurrence. And they do not do well, they get worse and worse, and their symptoms persist or even worsen. So this paper was also published quite recently. It's coming from Germany. Basically, they looked at the classical approach when the rib was removed here near the transverse process and from there on, and when the remove was extirpated completely. And they found significant, hands down, advantage of the total remove of the first rib. And it was done quite recently. So it was like 8 years since I started my approach. So I started my posterior approach, which was not new. I didn't know at the point when I started. So it was first reported by a surgeon, Kamran Aghayev. He was president of American Thoracic Surgeon Association. And in a presidential speech in 1962, he basically noted that thoracic outlet syndrome is a big problem in medicine. And he is the first one, and one of the first, to acknowledge the problem. And he introduced his posterior approach. Basically, think about how big it is. So this is kind of a half of the trunk opening to access the first rib and remove it. And what he did, and he achieved excellent results. But the morbidity of the approach was tremendous. You have to remove the scapula bone away to get access to the first rib, which created significant mortality. Later on, then the approach was basically, can we go, okay, I'll go back a little bit. Okay, so, and in 2015 or so, I started to get interested in this thoracic outlet surgery. And I thought about how can I improve it. And I developed the approach that I call the PURID approach, which is an acronym for Posterior Upper Rib Excision and Decompression. And so far, I've published 3 papers regarding that. The last one is not published. It was just recently accepted. And basically, this is how the procedure looks. This is just a schematics of, so we do a small incision, about a 4 centimeter incision in the back of the patient, and then we access the area of the first rib. And after resection of the transverse process, the algorithm proceeds with a splitting of the rib into 2 pieces, bigger piece and smaller. So we remove the smaller piece, which immediately decompresses C7, C8 and T1 nerve root. And then we detach the scalene muscle, the middle scalene muscle, and keep removing the first rib in a piecemeal fashion. And because it's benign pathology, there is no malignancy here, the piecemeal removal is possible and it's advised because it does not disturb the local anatomy very much. And this way, as you can see in this schematics, you can basically decompress the plexus, the artery, and the vein all together. And it allows a total decompression of the thoracic outlet area because the first rib is totally removed. And then after surgery, this is the things that I do. I usually inject the fat there to prevent fibrosis there. And this is postoperative scar. The first postoperative day after surgery, as I said, it's incisions about 4 or 5 centimeters. So this is the 3T reconstruction of the thoracic outlet area. The patient has been operated on one side. You can see the first rib completely absent on one side. So, intraoperative picture basically showing the entire brachial plexus from C5 to T1 with all trunks of the brachial plexus. So clinically, I think my case series is about like 150 or so for now. And so no lasting complications. We do have complications, but no lasting. So there are temporal complications like a Horner syndrome because of the manipulation of the sympathetic trunk, and hematoma and the pleural opening, but nothing lasting. And no residual ribs, obviously, and no recurrence. Some patients report good outcomes, some patients report excellent outcomes. And it puzzled me for a while. I mean, why some do better than others? And I looked back to the data and I figured out the only one factor that affects the good versus excellent is the follow-up time. As time goes by, the patients move from good to excellent. It basically shows that the improvement process is not finished in a matter of few days or few weeks. The patients keep improving years after surgery. And that's what I tell my patients, you just have the time on your side. So basically this concludes my presentation regarding the thoracic outlet syndrome, and I would like to switch to the next one. So this one is about direct sacro-lumbar stabilization, and the motto for this one is keep it simple and short. And by the way, when I talk about show no mercy, I meant show no mercy for the first rib. So the first rib should be removed completely without any residuals if you want to achieve good results. So next one is KISS. I'll basically explain it later on. So lumbar fusion, well, Tural, please don't raise your hand up. How many people here familiar with the concept of lumbar fusion? Good. We have two people, both neurologists. We have a third one who is quite unsure to raise his hand or not. All right. So spinal fusion is a procedure specifically we do in spinal surgery to unite or merge two adjacent vertebrae together for various reasons. It can be a degenerative case, infection, tumor, whatever. Okay. And basically, there are various options. You can see, bunch of terms here: TILIF, PILIF, ELIF, XLIF. I mean, all of the important things, they end up with IF, which means interbody fusion. And basically, the procedure looks like this. So we put a bunch of screws in a spine, and we put a spacer, or some people prefer to call it cage, in the disc space. And these two vertebrae fuse together, they become one, and the motion goes away, and that fixes the problem because there was some kind of a instability or pain associated with that level. But the way that we do it induces lots of problems. First of all, the traditional screws that we use in this type of surgery, they're not ideal. They are basically composites. They, for one level, for example, they have 14 different parts that should be assembled to hold the area, and that's why it's not very robust. It does not stabilize the level, and non-unions and the pseudofusions are kind of common. So this the problem actually has been in spinal surgery for years, non-union. So transdiscal stabilization is not new. I mean, they started in 1982 in a kind of primitive level. So this is, this is what they did. They just put the strut of bone here, hoping that there will be bone bridge between, high level of spondylolisthesis and S1 here, and they achieved. And that paper includes only just 2 patients. And then in 1990s, basically, other groups developed a little bit better technique where they put the screws and then the plates, and it continued to evolve, and basically Results were kind of satisfactory. This group, for example, put a screw into the from sacrum to L5, and again screws in L5 and connected with the old system. And basically, they reported, I would say, decent fusion results. I mean, the fusions are not so bad. I mean, 4 patients had a grade 1 fusion, which is a very good fusion. Then, from a biomechanical standpoint, this paper comes from Japan. They basically figure out that transdiscal stabilization is actually much better than standard stabilization and equal to the stabilization with a cage. So I did my part on that when I was a fellow of spine surgery, and we did a research, and we also reported kind of a comparable result between the transdiscal and so on. So after finishing my fellowship, I thought about what would be the next level. Okay, I did the research, I published the paper, everyone was fine. So what would be the next step? Am I done with that, or can I take the idea further? Which I did. So basically, I designed something I call now SLIF, Sacro-lumbar interbody fusion, which is a combination of a cage and the screws, which is an ideal combination in spinal surgery. And it should be applicable to all L5-S1 cases, not just the high-level spondylolisthesis. And it shouldn't be moving parts. But there were technical challenges. So you can see that this is a direction of a normal S1 screw. If you want to put a screw from S1 to L5, you basically can do it in a high-level spondylolisthesis, and that has been done for 40 years. And the screw will get into the bone and will get a very good anchor. But when you don't have a spondylolisthesis, the screw will not purchase any bone. So you have to redirect it. But when you redirect it, you basically endanger the foramen and the nerve there. So I came with a solution that you should start the screw from lower and go up. And in sacrum, you can totally do it because the foramens are going narrower as you go down. So there's a safe area called sacral ala where we can perform this one. So this is an entry point for standard S1 screws. This would be the sacro-lumbar, and that would be the direction. So another one would be collision, when the cage and the screw kind of hitting each other. So I solved the problem by moving the cage anterior. So I designed the study. Basically, I didn't want to take the idea and milk it. I didn't want to do separate study when I would do feasibility study, and I would do biomechanical evaluation, and I would do clinical study to get as many papers as possible. I just decided to do one paper, one study, and put it all in one. So you would read this paper and got more or less an idea of what's going on. So the study included 3 parts. It included cadaveric part, where we did a feasibility study. It included a biomechanical part, where we did evaluate it from a biomechanical standpoint. And the third one was a clinical. So we did all together. So this is the cadaveric part where we did feasibility. I'm just going to jump through it. We show that it's feasible and safe. So it does not hit any nerve roots, any neural elements. Next slide. Basically, the foraminal area is very safe here. The nerves are not being hit, and no collision between the cage and the screw. So that was the first part of the study. Then we did biomechanical evaluation, and we showed that it is superior, or in some testing scenarios, equivalent to the standard treatment. And in this case, when it comes to shear force, it's a particular biomechanical test we use, it's actually superior to the standard. And then we went to do the clinical part, which was not easy. So all the patients, 8 patients here. Now I think the number of my patients is about like 15, twice as much as was reported before. They developed excellent fusions. So you can see the fusion is here, is very, very solid, and they all improved. There's a clinical improvement. So that's what was done, and that's what I'm sharing with you right now. And I believe I came to the last slide of this part of presentation. So sleeve is extremely simple. It does not have components. It's not a composite system, and that's why I put a motto: keep it simple and short. It's much simpler and much more direct. So that's a paper that is published. It's in the public domain. You can easily download it and read if you're interested. And these are my old patents, okay? I kind of feel nostalgic, reviewing them. That's why I think I put them in. They are about to expire. In 5 years, they will be in a public domain. If anyone interested, you can use them. You don't have to pay royalties. Okay, so this is the last part, and how are we doing with time? We're good? Good, all right. So, and diffuse idiopathic skeletal hyperostosis, and the motto for this for this part of presentation is chips them off. More polls? Anyone familiar with dish disease? Okay, we got one person. Certainly, I specialize in a very popular area of research. All right. So, basically, dish is a disease that you may not heard about, but I'm pretty sure that some of your family members are really affected. It was basically reported in 1950s and by this guy, Posterior, and another name for the disease, the Posterior disease. And it's characterized by the calcification and ossification through the body. And it primarily affects the spine, though. So it's predominant in elderly. So men in the 6th and the 7th decade of their life, they have almost 30% prevalence of dish. So any man in this room, reaching up that stage, have a 1 in 3 chance of developing dish. And there is genetic predisposition to this disease. I'll be talking about a little later. And several metabolic syndromes associated with it. The hallmark is there is no inflammation. Spine is always affected. And there is not too much known about how the disease develops and how it progresses. And very little research and no treatment at all. And one of the reasons that the public and the medical practitioners are not familiar with the disease is that many people do not consider it as a disease. They just say it's a part of aging. That's it. They don't consider dish as a disease at all, and that's a big problem. So there are some basically genetic information done from Portuguese population and from Far East population. I just put it because I thought it would be fancy to put it somewhere. I don't understand anything that's written here. So this is how disease develops. So basically you develop bridging osteophytes in your spine, kind of merging the vertebrae together. Remember I talked about the fusion procedure when we want to merge vertebrae, when we want to unite them specifically. In dish disease, this happens spontaneously. So the patient is becoming rigid as the disease goes on. And in cervical spine, for example, it can be quite significant here. And it can compress the airway or esophagus and cause a bunch of problems with swallowing and with airway obstruction. So clinical presentation, pain. The hallmark of the disease is pain, pain, pain. It's a chronic, debilitating pain, and they go to a bunch of doctors, and some doctors do not even recognize it. They just say, okay, is everything okay with you? Go do some physical therapy, I don't know, holistic medicine, whatever. Just don't come to me anymore. And in some cases, the restricted motion, they feel like I'm rigid, okay? I just can't move as I used to be. And some people think that it's part of aging. They're not as they were in 18s. And accelerated degeneration. So in spine, we have this concept of accelerated degeneration. When the portion of spine is not moving, is not flexible anymore, the load shifts to other moving joints, okay? As a result, those joints suffer. And in DISH, we were talking about the entire thoracic segment. I mean, something starting from T4 or T5 going all the way down to T12. So the entire thoracic segment becomes like a bamboo tree, all right? And that's why there's accelerated degeneration. And they can get a fracture with a relatively minor trauma. They fall and they fracture the spine, which have a catastrophic consequences. Swallowing difficulties in cervical level, and its response to surgical treatment. So this is interesting. This is really interesting. So in cervical spine, when these osteophytes compress the esophagus, the airway, surgeons go and remove those, and it responds very well. But no one has thought about removing the thoracic osteophytes so far. And that puzzles me. Why on earth, for the 70 years of this disease known to medical field, no one thought about that? Well, I was wrong. There was a guy who thought about that. He was an anatomist, and his name was Nathan. And he basically dissected thousands of cadavers and basically found DISH in some of them. And he basically pointed out that the sympathetic nerves, that the lesser and great splanchnic nerves, especially on the right side, are being compressed by these osteophytes. And he wrote, I'm just going to read it out. We cannot draw conclusions from the current work regarding clinical symptoms produced by the compression of the osteophytes in the thorax because the study is based on cadaveric material. I mean, cadavers tend not to present any symptoms. All right? In previous works, we analyzed the possible symptoms that may be expected from compression of the sympathetic trunk in the abdomen and thorax. We assume the symptoms will result either from irritation or stimulation of the sympathetic structures or from inhibition according to the degree of compression. So I thought, because I was seeing these patients, they were coming to my clinic, why don't we remove them? Why don't we simply, brutally go there and remove them? And I did it. And I did in 2 cases so far. They both were women, both were elderly. And presentation for the first patient was a pain and restricted motion. And both were Azeri, by the way. They were from here, from Baku, okay? And this lady found me on internet. They came to me because no one could understand her symptoms. I figured out that she had DISH, and I did surgery for her. The second was a little bit complicated. Okay, she had a 40-year history of a pain on the left side, kind of a radicular pain, restricted motion, obviously. She had cardiac arrhythmias. She didn't think that related to that. I thought that it might be because of irritation of sympathetic trunk. She had up to 2,000 extra systoles every day. She could feel it. She should just take a pulse and she would feel it. She had some gastrointestinal problems which she related to previous cholecystectomy. She said that I had a cholecystectomy for like 40 years ago, and since then my abdomen doesn't work very good. Okay, so, and she has hypertension. So we did surgery for both 2 ladies. So let's see what happened. So this is the patient 1 pre-op with these osteophytes here. Osteophytes removed. It's the intraoperative picture, and these are the osteophytes we removed. I'm sorry, these pictures are not as impressive as Dr. Toral's video, okay? But nevertheless. And the clinical outcomes. 2 patients only so far in the world. Good pain control, no pain whatsoever. I didn't write it, but she also reported increased range of motion. reflex sweating. So as we remove the compression from the sympathetic plexus, she starts to sweat, and she starts to sweat more. We tend to think that it's going to improve with years, but I have to wait for that. The second patient, remember, she had pain and some arrhythmias and GI and problems with hypertension. So good things. The pre-op pain completely vanished next day after surgery. Then extrasystoles decreased to almost none. We did a Holter test before and after, so we showed that it's significant improvement. GI upset completely vanished, and hypertension is much better. She's off medications today, but she is in the 7th month, and she developed a T1 fracture because we chipped off the osteophytes from the anterior portion of the vertebra and kind of collapsed on itself. It's asymptomatic, it does not cause any pain, but she has chronic pain from thoracotomy. She's still in a recovery process, and me and my thoracic surgeons, we tend to think that it will get better with time, but now she has pain on the right side, exactly over the incision. So this is the second patient, by the way. Does anyone think that there might be something different about this picture? Any thoughts? No? All right, I'll tell you. So this lady here looks like she's smiling. She's obviously in pain. She's smiling because she was told to smile, okay? She's thumbing up because, we told her to thumb up, all right? But look at the faces. Do you see similarities? The patient is my mom. I did surgery for my mother, and she is in the 7th month. I was going to show her today, but she refused to come. So, and that's the end of my presentation. Thank you very much.
I guess refusing something is a mother's behavior, so... No offense from us. I love our mom. Thank you so much. For time, we only take one question. Okay.
Yeah, there's a question from pain management.
Teşekkürler. Kamran doktor çok meraklı kişiydi. Doğrudan çok inovatif yanaşmalardı. Zaten benim bir şey meraklandırır. Sizin nörocerrahi kabiliyetiniz, gördüğünüz cesaretli, inovatif işler tebdire layıktır. Bunlar güzel. Ama adın çektiğiniz üst patolojiya, Thoracic Outlet Syndrome, lumbosakral problemler, o cümleden idiopathic, hyperostosis, Posterior diyesen veriyor.
Posterior.
Bunlar üçü de diagnostik olarak çok çetin geç karar verilen problemlerdir. Mənim maraqlıdır. Siz ciddi əməliyyatlar etmişsiniz hər pasiyentdə bu diaqnozlara görə. Amma bu ciddi əməliyyatlardan qabaq bütün müayinə imkanları, yəni burada revmatoloji olsun, nevroloji olsun, filan olsun, fonksiyonal vesaire bunlar hamısı oldu mu? Niye? Çünkü biraz evvel karşıda da bir danıştık. Thoracic Outlet Syndrome, diferensiyasiya çox çətin. Hətta siz deyirsiniz, mən fikirləşirəm, bəlkə orada interskalen sindrom olur. Məsələn, oldu mu interskalen blok edən və brachial plexusu orada ayırmağa çalışanda hidrodisseksiya və yaxud lumbosakral problemlərdə biz başlasaq yuxarıdan, təbii ki, sizin spondylolistezise qarışmıram mən də, glunial sindromdan aşağı gələn işvofemoral impingementə qədər onlarla diagnoz qoymaq olar. Tek bir şey diyeyim, siz nörocerrahı bunu yaxşı bilirsiniz de, sacro-tuberous ligamental strain olur. Sacrospinous ligamental strain olur. Heç diagnostik olarak çok çetindir bunlara bir karar vermek. Bu taraftan trachanter bursta geleceği, oradan kalsa problemleri falan bunlara gelir. İdiopatik hyperostoz ve ankilozlaştırıcı spondiloartropatiya. Bunların diferensiyasında yine tabii siz o autoimmün problemde bu degeneratif falan ama kifayət qədər iç-içə məsələlər var. Məsələn, sonuncu case'də deyək, olardı mı öncə splanxik bir radiofrekans ablatsiyası eləməkdə həmin əməliyyatdan əvvəl. Çünki dediyiniz problemlərin xüsusən birinci thoracic outletlə sonuncu, bunlar həm də kompression işemik neuropatiyalara aiddir müəyyən qədər, daha amma aktiv case'lərdir. Məsələn, belə situasiyalarda bir sıra hallarda klinik əlamətlər ikincili kompresiya nəticəsində ortaya çıxır. Niyə ikincili deyirəm? Çünki uzun müddət o münasibətdə sümüklə deyək, sinir durmuşdur. Niyə başladı? Hansısa hərəkətə bağlı ikincili bir kompresiya yarandı, orada ödem, inflamasiya və ağrı başladı. Və biz başqa yollarla onları götürə bilirdik. Biraz uzun sual ama istəyirəm onu deyəm ki, bu ciddi qərarları verincə bütün imkanlar yoxlanıldı mı bu məsələ? Təşəkkürlər.
Sual aydındır. Sual aydındır. Azərbaycanca bildiyim qədərlə cavab verməyə çalışacağım. Thoracic Outlet Syndromunda birincili olaraq xəstədə nevroloji defisit yoxsa mən şəxsən əməliyyata almıram. Bütün xəstələrdə nevroloji defisit var. Hətta xəstələrin əksəriyyətində əldə atrofi olan xəstələri alıram artıq. Yəni artıq atrofiya başlayan xəstələrdə alınır. O ki qaldı Thoracic Outlet Syndromunun diaqnozu tamamen haqlısınız. Burada bir standartlaşdırılmış yöntem yoxdur. Yəni bir standart bir protokol olsun və onun nəticəsində xəstəyə TOS diaqnozu qoyaq, elə bir protokol yoxdur. Amma qollar yuxarıda MR çəkiləndə, xüsusən costoclavicular impingement, köprücük sümüyü ilə birinci qaburğa arasındakı məsafənin kritik dərəcəyə düşməsi və brachial plexusa bası olması bu bir göstəricidir. Vaskülər daha rahatdır. Vaskülərdə anjiyo eləyərsiniz, qolu yuxarı qaldırarsınız, axım yoxdursa diaqnoz asandır. Amma vaskülər nadirdir. Nörojenik TOS əsasdır. Onun da diaqnozunu bir, nevrolojik defisitlə, iki, bir də baskını MRT-də göstərməklə qoyuruq. O ki qaldı interskalyan bloklara. Bu mövzuda Baltimore'dan Julie Fischlager'ın çox yaxşı bir çalışması var. Onlar interskalyan blokların diaqnostik əhəmiyyətinə baxıblar. Yəni nəyə də baxıblar? Əməliyyat olan xəstələrə retrospektiv baxıblar diaqnostik blokların və diaqnostik blokların positive predictive valuesunu, yəni diaqnostik bloku elədiniz, xəstədə blokun nəticəsində TOS diaqnozu qoydunuz, bunun faizinin sadəcə 30-38 olduğunu göstərmişlər. Ona görə çox da güvənilir bir test deyil diaqnostik blok. İkinci, spinə gəlincə, L5-S1-ə gəlincə, L5-S1-dəki patologiyaların hamısında radikülər bulğu vardır. Hamısında radikülər bulğu var. Orada hani heç tartışmaz. Əksəriyyəti daha öncə əməliyyat olunmuş, failed back'tir, daha öncə əməliyyat olunmuş, ikinci mərhələdə füzyona gedirlər. Bəziləri ilk mərhələdə füzyona gedənlərdir. Hamısında radikülər bulğu var və nevrolojik defisit olan xəstələrdir. Ona görə orada da diaqnostik problem yoxdur. Dediyiniz, qaldırdığınız mövzu, diaqnostika mövzusu ən çox diş xəstəliyinə aiddir. Çünki birinci diş xəstəliyində bəli diaqnoz var. Diaqnozda kriterlər var. O kriterlər 1970-lər qonulmuş bir kriterlərdir. Amma o osteofitlərin splanknik sinirlərə basısı olub olmadığını heç bir şəkildə göstərmək hal-hazırda mümkün deyil. Splanknik bloka gəlincə ya da ki splanknik ablyasiyaya gəlincə. Mənim elədiyim cərrahidə əsas məqsəd splanknik sinirlərin üzərindən basıyı qaldırmaq, onları qorumaq. Ablasiya tam tərsi, o sinirlərə termal bir hasar verərək onları yox etməkdir. Mənə elə gəlir ki, sinir avtonom belə olsa, siniri qorumaq, ona termal bir hasar verməkdən biraz daha gözəl olar. Amma haqlısınız. Yəni, preoperativ olaraq heç bir şəkildə splanknik sinirin basısını hal-hazırda tam dəqiqliyi ilə göstərmək mümkün deyil. Bu biraz intuitivdir. Və biraz da aslında baxsanız, yap və gör. Yəni, biraz şeyə qalmış, şansa qalmış bir şeydir.
Teşekkürler. Azerbaycan'dan sizler.
Sağ olun.
Çok teşekkürler. Tamam. Muhteşem.